Great. Well, thank you guys for having me. We'll kick off the lecture. So today we're going to talk about orthobiologics in seniors. So you can see here, and again, I do a lot of this orthobiologics. We had a few patients even today that came in and want to talk about it. So this is a good topic and a great time now to talk about it. So first off, a special thanks to Dr. Brian Cole. He's really the sort of godfather of orthobiologics, and I was fortunate enough at Rush for him to be my mentor. And you guys probably watch any videos on biologics, you'll see him as one of the main presenters. So the objectives today really discuss current usage of biologics in orthopedic surgery. We'll discuss types of biologics available, and then what's the current evidence in literature. And again, this is a broad topic, so we'll try our best to summarize as much as we can. So we're going to talk about PRP and how it relates to musculoskeletal injuries. We'll review stem cells and their use in orthopedics. And then we'll recall some of the biologics that can help with surgical outcomes, and then how we combine this in some cases. So here's the current landscape. This is 2020. Again, there's a number of different things in where they fall down, and we're not going to sort of go into each one in depth as much as we can, but we'll start on the areas that I think are more significant. So you have cytokines, and we probably won't have time to talk about those today. And then you have PRP, which we'll talk about a lot. And there's the two main types of PRP, which we'll get into shortly. And then we're going to talk about stem cells. So there's the two types. There's stem cells from your own body, and that's the stem cells from adipose tissue or fat, and then stem cells from your bone marrow. And then there's allogeneic ones where they're harvested from somebody else, so bone marrow, adipose. And the one you see a lot in the city is the cord one. That's the renew or the amniotic fluid one. So what's the need, though? Well, we're talking about elderly patients or patients above 60, 65, whatever you want to call it. 52 million in the U.S. are diagnosed with OA. In my office, I probably see a few a day with osteoarthritis that want to come in and talk about biologics. 62% again are over 65, and we do over 1 million joint replacements a year. And this is a few-year old slides. This is probably even outdated now. It's continuing to increase exponentially. Also, what's the other problem? So above 60, above 65, a lot of people get rotator cuff tears. So incidence 10 to 30% of the population. 5.7 million people in the U.S. with rotator cuff tears. We do about 270,000 rotator cuffs a year. It's one of the most common surgeries that I perform. And unfortunately, there's this 40 to 60% re-tear rate at 1 year by MRI. So we have to figure out a way to do our surgeries better. Then there's tendinitis and soft tissue injuries, and this goes on and on. But you have 66 million healthcare visits, 4.5 million sports injuries, and these all require medical attention. So, but that's not what we're here to talk about. We're talking about orthobiologics. So these are substances found naturally in your body, and they really help you heal more efficiently. So you have certain materials such as bone grafts or autologous blood, and then you have artificial matrix materials, and then we have growth factors. We'll talk about PRP, and then you have BMPs, which are part of the PRP and stem cells we'll talk about. And then you have stem cells themselves, so you have progenitors and mesenchymal, and we'll get into that shortly. So what's the problem? Well, the problem is you have a lot of unproven stem cell clinics. I mean, there's a number of them even in the city here that you may know of. But you can see we have the highest density in the world of online stem cell tourism. And this is a problem. And I spend a majority of some of my clinic visits trying to convince people not to go into certain different things and spend $10,000 on a stem cell injection when they could have something that's still an injection of some biologic, but a lot less expensive and a lot more efficacious. So I updated this for 2020, and I just did the Google hits, 29 million hits for PRP. And it gets even more impressive when you type in stem cells, 447 million. So there was a lot of people out there trying to post stuff about this, and there's a lot of information that can overwhelm people. So PubMed is one of our major our academic article sections. You can see up to 2016, it's exponentially rose, and this will continue to rise and has continued to rise now that we're in 2020. So here's the thing, what's marketed to us, surgeons? So you can see here's a list of a number of different products that are available. You can see the unfortunate thing about this is you can see number of peer-reviewed articles. It's really not that many. And this is what, all over the booths, they're talking about this. And these are doctors that understand all this stuff, and you're trying to sort out what's the right thing to do for the patient and what the data is just not great on. I highlighted in red, these are the products that I use. I do have some of the other products I occasionally use, but these are sort of the most understood, the most literature-based products. You have MACI, ACI are basically the same type of thing. PRP, we use a lot of that, and there's a lot of good clinical studies, and I think 59 is under representing that. Allografts for cartilage transplants, et cetera. And there are a couple of small things that are not listed on here. But it's just something for you guys to understand that there's a lot of things out there that have very little literature on them, at least for good studies. So what's the rationale? Well, you can use it alone, or you can use an adjunct to surgery. And I think I use these in both directions. And it's important that you understand this. This is why it's hard for non-surgeons to deal with biologics, and for the other direction as well. So it helps to have that combination of training. So anabolic and anti-catabolic molecules, they modify the arthritic process or regenerative process. That's some of the thought process of why we use biologics. And we can modify, we hope, cartilage, synovium, mesenchymal scales, and subchondral bone. So again, this is sort of the things that we get to do, the fun stuff I get to do in the office. Now, again, this doesn't relate to someone over 65, but these are some of the ways we can transplant and add biologics to make this sort of, to make our procedures better and for them to last longer. We won't go too much into this because we're talking a little bit different stuff today. But here are the options. And again, we all want to talk about the fun, sort of sexy stuff with the PRP and the stem cells, but you have to start with the cortisone because that's really the first option for a lot of these patients, and they have to understand what they're getting into if they decide to pursue this or skip to the next step. So this is a good article. It's a little older now. But this is something I talk to my patients about because we see this frequently. They come in and they say, I've had a couple cortisone injections. They've stopped working. Do you know why? And really what we found in the data is that cortisone injections are effective, but in a lot of cases, the relief can last up to only a week on average. And this is a level 1 review of studies. So it's something that's important to talk to them about. Again, it's the least expensive. It's the one covered by insurance. So we obviously want to try that option first. But here's the problem. So here's another JAMA article. I mean, these are high-level journals. These are not published in sort of odd journals. These are steroid injections at 3-month intervals for over 24 months. And these are moderate grades, so KL grade 2 and 3. So we're talking about, not complete bone on bone, but arthritic changes. And you can see here, if you just got saline injections versus got the cortisone injections, you had a less loss of your cartilage. So, and unfortunately, at 2 years, there was a significant loss of cartilage and no significance in knee pain at that 2-year mark. And so we're actually increasing their chance of knee replacement by giving them cortisone injections. So you can see there's sort of difficulty in this process. So what about supplementation? This is basically hyaluronic acid. Well, unfortunately, my academy orthopedic surgeons eventually came out with some recommendation. They strongly recommended against the use of HA. And as a result, in the last 2 years, the insurance companies aren't paying for it for the most part, which is quite frustrating. Above 65, Medicare still pays for it. But this becomes a difficult situation as someone who's 60 with arthritis. Now, here's the problem. There's a lot of good data out there that shows, you can see in the bottom here, 3.6 to 7.6 years you can postpone a knee replacement by using it. And I have a lot of patients that really get good benefit from it. So it's really unfortunate that they're now having to think about paying out of pocket for this when it was covered easily before. And then there's been 2 other articles coming out, and there's a lot more than this. These are just sort of the higher level things that basically the AAOS missed the mark here. And of course, insurance companies jump on that. They love the fact they don't have to pay for it anymore. And there's a closer examination. This is JBJS. This is basically one of our best journals that we have. Examine that it's extremely effective in certain situations for knee arthritis, but unfortunately, insurance companies right now, majority of them are not paying for it, at least the private insurers. So then let's talk about the stuff everybody came to here for. So PRP, and we'll get to stem cells next. So PRP, so what these platelet activation, they release certain growth factors. And these have various effects, and we'll get into them in a second. But you can see here, there's PDGF. This is cell growth, new generation. There's FGF, so tissue repair. You have endothelial growth factor, TGF beta, et cetera. So there's a number of growth factors, and this is where we think that this can help patients with certain issues. So there's multiple applications. So you have these alpha granules that contain the various factors and cytokines, and these concentrations are equal to platelets. So you increase this sort of cytokine activity with TGF beta, PDGF, insulin-like growth factor, you have fibroblast growth factor, et cetera, and all these things can help with cell growth and essentially cause a potent anti-inflammatory as well. Here's the problem. There's multiple system preparations. If you look on the market, there's over 80 available. And the problem you have with some of these studies is they use different systems. And there's been head-to-head studies showing that each system varies in terms of how long you spin for, what type of product you get. So you need to be really careful. And there's really only a few products that I sort of endorse that have been consistently effective. And they differ in the platelet level, white blood cells, and the amount of growth factors that you have. So you need to understand that, because someone may choose to have a cheaper system because it's less expensive overhead costs, but it's not as effective. And this is something you need to pay attention to when you're reading the articles as well. So this is just a very brief overview of the systems. So you have this plasma-based PRP single spin system, and we'll get into why it's important, but this produces less platelets and fewer white blood cells. It's faster and cheaper, so this is what we call ACP. A majority of places, even the high-level guys like the Seahawks, they have only one of these machines. That's the ACP. They don't have the double spin, which we have both in my office. So the double spin is for a different type of PRP we'll talk about, but it's more expensive sort of setup and everything else. But you can get different types of PRP, which is really good. The single spin ones for mostly we call leukocyte poor, and the double spins mostly for leukocyte rich. And there's a few companies. I use Arthrex. That's the ACP option, and this is the Angel option you're seeing here. So here are the PRP types, and it does matter. And unfortunately, I think a lot of people don't understand the different types and why you use them. So they say, okay, everyone needs ACP, and then people are getting injections into their tendons that are getting the wrong type. And you'll see it matters in the studies. So you have this leukocyte poor option, which is good platelets. You see here, two pluses, and very little white blood cells. So that's really good because it doesn't inflame where you're putting it into. And this is more of an arthritis option. And then you've got pure PRP, and people are still investigating whether this can be useful or not. And then finally, you have leukocyte-rich PRP. So it's important to understand that that's high white blood cells. And so that causes inflammation. So that's something you use for lateral epicondylitis, patellotendinitis, etc. So here are some basic science stuff. And we'll get into more of the clinical stuff shortly. But you can see they tested how these react to synoviocytes and whether they cause cell death or allow them to survive. And you can see here, again, this is why it's important to understand the different types of PRP and what you're getting with your machine. But you can see on the leukocyte-rich portion, there are a high number of inflammatory markers. But if you have the poor, which is the one that's right below that, so LP is poor, LR is leukocyte-rich, you can see it has a high number of anti-inflammatory markers. So do you want something to calm down, such as someone with arthritis, you want the anti-inflammatories to be high. If you want someone to have a tendon healing, you want high inflammation in that area to cause it to heal itself. So what are its effects on tendon tissue? Well, there's increase in sort of PDGF and TGF beta to essentially cause the healing. Then you have increase in sort of blood flow and vascularity at the site, and they act to enhance the sort of proliferation at the injured site. And this is a leukocyte-rich formula. Again, we in vitro here, earlier healing, good quality of healing tendon, and better organization of collagen. So how about muscle strains? Well, we won't go into all the basic science, but basically it showed that the PRP can reduce inflammation, increase the progenitors for muscle cells to repair, and shorten recovery time. And again, this is looking at the ACP set. So here's some more clinical studies. Again, looking at PRP and muscle injury, and this is a meta-analysis. It suggests that PRP may have help with sort of acute tears, grade 1, 2. But again, the question is, how much does it help hamstrings? So we're sort of on the fence whether this is the good option or not. If you're a professional football player and you have to get back in one game sooner, the economic benefit of that is humongous. So if there's even a little bit of a benefit from it, we're going to use it in this situation. Well, how about PRP versus saline? That's important as well. We got to find out if this is a placebo effect or not. Well, this is a study here in AJSM, one of our big sports journals, 15 per group. They got three weekly injections. Okay, so again, they will see the difference between one injection of PRP or over a 3-week period. And at 12 months, you can see 78% had an improvement in the PRP versus 7% in the saline. But what's interesting is it's not immediate. Again, most of the time I tell patients 4 weeks. You can see here, 2 weeks, they start to separate out, and it's statistically significant after 2 weeks compared to saline. Well, what about HA? Well, HA sounds great, but head-to-head, and people ask us all the time, how does it do? Well, really, PRP is the sort of winner in these situations. So you can have hyaluronic acid versus PRP. Now, here you see it's almost out to 2 years. 1 year. But you can see that the HA and PRP have a similar course, but PRP is better on all time points. And you can see where it breaks off is roughly around the 4-week mark, and that's what I tell my patients. So here's, again, another discussion of poor versus rich, and a lot of people do not understand this. So it's important that I hammer this home, because if you look at studies and it says PRP doesn't work, there are studies that can show that, but you have to be careful what PRP are you looking at. So you can see here, they treatment 1 and treatment 2, these are randomized controlled trials, level 1, or you have level 2 studies. So pretty high level. You can see that looking at this, they sometimes use rich, they sometimes use poor, and the ones that did better were the ones that had the leukocyte poor. This is for knee arthritis. And this is at a study out of where I did my fellowship at Rush. So leukocyte poor better than hyaluronic acid, better than leukocyte rich, and better than placebo. And so this is why I tend to sort of lead my patients towards this. The unfortunate thing is the insurance companies don't pay for it. So what about combining this? So a lot of times we would combine PRP and hyaluronic acid. PRP does have some hyaluronic acid properties, but the synergistic effect has definitely been documented. You can see here on 3 major studies. So I tend to use them in combination if I can, and likely hopefully can get insurance to approve at least the HA side of things. Well, what about sort of more in-depth thing? There's low molecular weight, there's high molecular weight, and sort of when can I give this person PRP, or when should we say, you know what, it's not even worth your time, you should get a knee replacement? Well, here's 3 injections, okay, again, so not a single injection, 3 injections a week apart roughly versus hyaluronic acid. You can see here at 2 and 6 months, the PRP did better than the hyaluronic acid, but as patients aged and as the cartilage got worse, it was less effective. So the early arthritic patients, you can see there in the middle sort of portion, did better than the patients with advanced OA. And so patients with advanced OA, for the most part, I try to lean them away from this. I'm fortunate enough in my practice to see patients sort of at the earlier stages, and so I can give them benefit with this injection option. Well, does number matter? Well, I've kind of keep bringing this up. This is a guinea pig study, but again, it's a good information. It explains sort of 1 versus 3. So you have 36 pigs they looked at, 3 treatment arms. So control, 1 PRP, 3 PRP. So G2 is PRP with 3. And you can see that when you give 3 injections over a week-long period, it was the only one that continued to be effective after 6 months. And this is articular scores. So you can see multiple PRP injections needed for long-term effect back 6 months. The problem is, for most part, these is more expensive. We're talking about 3 times more expensive. So I tend to tell patients, should we see if you're the PRP person? We do 1 single injection, see how they do. And then I have a lot of patients eventually that opt for the 3, but we start off with the 1 and see if it's effective enough for them. So this is a little outdated study, but I want to bring it up because it's a really good summary slide. But basically, looking at all the different things here, you can see if you got to make sure you remember that PRP leukocyte rich was included in here. So there were 2 that didn't show significant difference or did worse. Those were both rich formulas. When you have poor, you can see significant difference in the 2013, 12, 12, and 12 studies. So it's important to understand that there is a big significant difference against baseline and hyaluronic acid if you use the correct formula. So let's go into each topic, because this is what I get. Patients come in, they ask about all sorts of parts of their body and whether it's effective or not. So this is another summary slide, which I like these a lot because I think it sort of summarizes all the literature the best you can with what data you have. So this shows against controls, sort of equal effectiveness at 3 months. Then you have one where it's actually superior at 6 months. And again, these are usually non-surgical for the most part, so it's harder to get good orthopedic studies when there's not as much surgery involved in it. You have another one here, PRP better DASH scores and pain scores. And this is 2-year follow-up, so that's pretty effective. And again, better DASH scores at 1 year compared to saline or sort of glucose injection. Well, let's dive into this deeper. This is a better sort of summary slide. And this is from another meta-analysis. So you can see now, unfortunately, in the top one, it wasn't significant, but they compared it to surgery. And so we'd like to avoid surgery. So comparing it directly to surgery is hard and actually did about the same. You can see here, so DASH scores were better in this study against injections. There were a couple studies that showed there was maybe less significance. But again, you're trying to put these all together to get the best option because you never know where there's bias involved. But you can see in some of the higher level ones, 230 patients, 100 patients, 100 patients, the pain scores were significantly better than cortisone injection alone. And these patients, I still consider cortisone first, but PRP is what I'm quick to go to if that doesn't work. So what about another good meta-analysis? This is pretty new. I just put this in for this lecture. 37 articles. They looked at the sort of major things people talk about: rotator cuff tears, epicondylitis, tendinopathies, etc. So you can see here, this is sort of a plot chart. When that triangle is beyond that black line, that's some statistical significance, and very significant is when it's past the dash line. So you can see here that rotator cuff tear, there's maybe some possibility this may help a little bit, and we'll talk about that. ACL tears, there's been some discussion on this. There's no benefit to that, and I never offer that for those. In epicondylitis, there is a significant benefit, so I feel very comfortable offering this to my patients. So how about medial epicondylitis? Well, I see way more lateral epicondylitis than medial epicondylitis. But this is a good study that just came out. This is from Tulane with Savoy, who's a very good surgeon. 33 patients. So they did 2 leukocyte-rich here because it's tendon versus surgery. 1-year follow-up. They had almost equivalent success rate in both, whether you got surgery or not, or did the PRP injection, which is pretty impressive to me. And they did faster range of motion, which you'd expect because it's not a surgical procedure. But what pain-free is pretty impressive too. So half the time. So I have no problems, and I really try to convince people to try this at least once before going down the surgical road for these types of issues. Well, how about patellar tendonitis? I see this all the time, once a week at least. Generally, for me, it's in the younger patient population, but it's important to understand. So this one's against dry needling. So that's essentially the same thing I do with the PRP option versus they have this leukocyte-rich option. You can see it's better scores. And then you have here 3 injections 1 week apart, showed back to sport almost all of them without any surgical intervention, which is really good. So these are just something to think about. And there's been a number of other studies. We just don't have time to go through everything here. How about rotator cuff repair? Well, it's not great for rotator cuffs. I think people like to talk about it, hope that that's going to be the next sort of thing we can do to help people get their rotator cuffs healed. But in this situation, that's not the case. So it's important to understand that. But overall, you can see it does maybe help some pain scores, but did not help in healing. UCL tears, not as much in the elderly, so we'll kind of skip this. But overall, we found that leukocyte-rich is beneficial, so I'll do this in my high-level baseball players. Glute medius tears, this happens a lot. I've had a number of people over 65 that have come in for this. This is a more recent study, 2019. Actually, had a family friend that had this. I did this on him and did quite well. And you can see here, these are glute medius and minimus tears, which are extremely common in someone above 65. We just tend to sort of underappreciate this. Grade 1-2 tendinopathy. The steroid injections maxed out at 6 weeks, and the leukocyte-rich continue to get better. The other problem you have with cortisone, which is not shown here, is the complications. If you get a glute medius muscle tear and it keeps getting worse, it's a very, very difficult thing. And most of the time, there's no surgeon that'll try to attempt to fix that. So if we can avoid further damaging the muscle with just a regular PRP injection, I think it's worth it. Well, what about meniscus repairs? Well, people always ask, can you fix my meniscus with a PRP injection? The answer is, while this shows that if you do have an isolated repair, it does help a little bit. There's some caveats to it, but basically the summary of this slide is if you do the right surgery for the patient, you don't need to use PRP. How about hamstring tears? A lot of people have partial hamstring tears, etc. Here you can see the return to play is a little bit faster. I generally don't jump right to PRP with a hamstring tear unless it's one of my athletes in my college, high school, or professional athletes, because getting back 1-2 games sooner is a huge economic improvement. But overall, it is something people are investigating still. So we're going to go to we're going to skim this part over because I know we're all okay on time, but I don't want to run us over. So this is the sort of biologics combined with the surgery and all the fancy things I get to do in the office. Not as much as related to this talk, so we'll sort of skim through it. But this is how I decide. So you can see all the different procedures in that one knee on the top. We have debridement, so we can kind of clean up this cartilage. And we can do microfracture, so poke some holes and try to get something to grow. Biocartilages for small lesions. And then we can transplant someone else's own cartilage into another part of their body. And we have MACI, where we can grow their cartilage in the lab. And then we have fresh cadaver cartilage that we transplant. I tend to do majority of my surgeries are the bottom 2 because I tend to see patients with bigger lesions. So biocartilage, that's where we sort of have this cartilage graft. I call it sort of baby cartilage. And we actually can paste it onto the area after you've sort of poked holes, as you see there on the bottom. And you can see here, compared to just microfracture alone, it does significantly better. So this is another way we use this plus biologics. Well, how about the MACI? The MACI is where we grow in the lab. So again, for cartilage defects, we see pretty good results because these patients otherwise are waiting as long as they can to get a knee replacement. So 73% return to sport. Again, microfracture alone compared to the MACI, it deteriorates at 2 years versus the MACI kept continuing to be better. And return to play at 75% with these huge, big defects is pretty impressive, especially for the kneecap. How about cartilage transplants? Well, that's pretty high, 75 to 88%. That's what I see in my practice. But that's something to think about. Again, a lot of patients over 50 come in asking for this. Unfortunately, they're not candidates. Insurance will not cover that. But it's something that they need to know at least because people ask me all the time above 60 if they can have their cartilage transplanted. Again, if they have even more than one defect, we can still do it. And over 40 years old, it's still not a contraindication. 50 becomes difficult because of insurance costs. So let's talk about stem cells. So you'll hear a lot about this in the news. So you have all these different types of stem cells that we had mentioned previously. So what's the traditional thinking? Well, we think, or what you're told on the news is, or from an advertisement, is they pop the injection in and then you get all these progenitor cells being made and you can make pretty much anything you want from it. Well, unfortunately, it doesn't work like that. It's really the contemporary thinking of what at least the biologic guys know is it really just is a really potent anti-inflammatory. It does recruit some other stem cells with factors in there, but you're not actually injecting a stem cell that's causing it to change into new cartilage. These are like growth factors, so it's essentially just like a slightly souped up PRP with a little less data. So here are some strategies. Now, again, I do majority of the surgical PRP, the surgical stem cells. I do this less often than PRP because this requires an operation. And you can see here the video running of how we prepare it. And then there's certain types we have to do, so I'll explain that. So does it work? Well, they're not as good as studies, but there's a lot of basic science data. So you can see this is marrow cells. So we usually do bone marrow aspirate taken from someone's pelvis. And there's good to see clinical improvement and improved scores. And then this is talking about adipose tissue. So it's kind of silly to talk about it like this, but it's essentially like a little liposuction. You can take it out someone's fat, you can mix it together, and there are some stem cells in it that have proven to be beneficial. Now, again, this is something I don't offer very often because the data is not nearly as good as PRP. Now you can see here, the fat cells show this increased prostaglandin synthesis, and this is on very high level MRI studies to sort of see, are you getting, what's the quality of the cartilage that you're getting when there is some improvement seen. You can see here the sort of belly's been covered, and that's where the fat was taken from, and now it's being injected back in the knee. And similar thing here, improved scores. Now again, level 4 study, not great, not nearly as good as we saw for the PRP. Same problem holds true for this. Bone marrow aspirate devices are just the same number as you have PRP, so you need to understand which one you're using and whether it does the right thing you want. And then you got to find out where you're going to take it from. Well, in surgery, I could take it from all these places: the tibia, the humerus or the shoulder, and the iliac crest. In the office, most people do it from the iliac crest, and they do it from the back. That's why I've done it. But in surgery, when I combine things, I usually take it from the body part. It's just easily accessible. Unless it's a professional athlete, then I will do it from the iliac crest because the quality is a little bit better overall. Now that data is still out there and whether that's fully true. So let's look about arthritis. Well, you have here, this is a good study. It's another meta-analysis. This is from Vail, Colorado, a great sports place. Bone marrow aspirate for knee array shows encouraging results. Unfortunately, adipose tissue in this one did not do as well. Bone marrow aspirate did better. Bone marrow aspirate here improved the function overall. And again, these aren't high-level studies, but there's just enough that you're going to get a summary. This is looking at defects. Now, again, these defects a lot of times were additive to a surgical procedure. So there was improvement in all these areas, but it's just something to be aware of. So here you have another further discussion about this and more studies talking about this similar cartilage stuff. So what about this sort of bone marrow aspirate for OA? So again, 11 studies, some were prospective, a lot of them were case reports. Now, we can say it's safe, and that's really the good part about this, but there still needs more evidence. And there's a lot of basic science that shows this is good, but we don't have a lot of evidence compared to PRP for stem cells. Well, which one do I choose? Well, there's bone marrow aspirate. You have less stem cells. You have more hematopoietic stem cells and more effective hematopoietic stem cells. Now, in the adipose tissue, you have more mesenchymal stem cells, similar number, but shorter lived. So there's no real clear winner. Again, if something's needed, I tend to lean towards the bone marrow aspirate, but adipose tissue has shown some good studies as well. Now, this study is important because patients without tears of their rotator cuff had 3 times as many stem cells compared to those with tears. And so we think, okay, did they lost stem cells and that's why it's not healing well, or that's why it didn't heal, or that's why it tore? And there's actually some study that show you can now take stem cells, and there's devices we take stem cells from the bursa of the shoulder during the surgery, which is quite interesting. So here again, biological augmentation. This is Hernigo, so he's a pretty big deal in terms of the biologics section in Europe. Here's 45 bone marrow aspirates with rotator cuff repair versus only rotator cuff repair. And again, this is a high-level study looking at different MRI sequences after tendons were healed. 87% healed with the stem cells, only 44% with the non-stem cells. I think that number is a little bit low at 10 years, but it's just something that's a good study to mention. So in conclusion, PRP and stem cells for OA PRP leukocyte poor for OA is becoming a dominant treatment strategy. This is one of my most effective strategies. Obviously, cost is prohibitive for certain patients, but this is what I tend to recommend. And a lot of my partners and I have done it before for their needs as well. So it's something that we really encourage. Bone marrow aspirate, good science. Clinical evidence is lacking. It's very expensive. So I tend to do it if I need to for professional athletes, certain patients that have failed everything else and want to try one more thing before knee replacement I'm interested in. I feel at least I'm giving them something, but I don't tend to do that as my first line. Rotator cuff repairs, PRP may work in some settings, but not really my advantageous area. And then for the bone marrow aspirate, there's still more study required, and we're doing all these fancy things now with patches and everything else. And can we add this together? So I didn't even get a chance to touch on that, but that's a new area. And I think in the next 2 or 3 years, you're going to see more improvements in this area. This is a very busy slide, and if at some point they want to get my slides out, this is a great sort of like handout card you can use. But you can see here, each of the different types of PRP and a summary of them, indications you see up there for the PRP, and then the bone marrow aspirate, similar ways that things we help with the bone marrow aspirate as well, rotator cuff tears, epicondylitis, tendinopathy, where the highest yield is. Everything I talked about is basically summarized in here. The important thing is patient-specific factors. So it is higher in males, it's higher in younger patients, so those patients tend to do a little better with this, but patients above 65, it still has a lot of efficacy. Exercise is really important. So the more you exercise actually increases your PRP level. And I tell patients, why don't you exercise a week before? And that might improve your levels. And I find that people that are more fit and active tend to have a little better PRP take. And I think that's it. That's about 35 minutes.